Okay, shall we start? So Talita Voorn will be presenting a paper on Brugada syndrome. And I think it's an interesting topic. There has been a lot of controversy about the Brugada syndrome, not only by the role of the sodium channel mutation, but also about the mechanism of arrhythmias in it. And originally it was thought to be a disease like long QT syndrome, so only functional and no structural abnormalities. But in the course of time, it has become clear that there are structural abnormalities in all patients with Brugada syndrome, almost. And in fact, that a message that I try to convey is that the sodium channel mutation is a modulator of these arrhythmias. And I think Talita will discuss a paper that more or less connects to this, if I'm right, Talita. Yeah. So please go ahead and show us what you found.
Yeah, well, welcome everybody. For the people who don't know me, I'm Talita. I'm doing the Master 2 at Lyric. And I'm now currently doing my internship in the hospital in Olevec. Also on Brugada syndrome, but more the clinical setting of it. And for the journal club here, I thought it would be interesting for you, but also for myself to get a little bit more into the basic science of the pathophysiology of Brugada syndrome. So I chose this article, Normal interventricular difference in tissue architecture underlie right ventricular susceptibility to conduction abnormalities in a mouse model of Brugada syndrome. And it's an article that has been published in the ESC, European Society of Cardiology, in 2018. And the last writer is Godfrey L. Smith, which is a cardiovascular physiologist in Glasgow. What I'm going to tell you is I will first start a little bit for an introduction of Brugada syndrome, because I was not sure if everybody knew about the syndrome and about the disease. Then I will tell you something about previous research that has been done with the RV, but also the arrhythmias. Then I will discuss the results of the article, and I will form my conclusion, and probably afterwards we'll have a discussion about it. So first, what is Brugada syndrome? Brugada syndrome is a genetic disorder that has been linked to ventricular arrhythmias and sudden cardiac death, and more often also in young people, so between 20 and 40 years old. There are three kinds of patients who get diagnosed with Brugada syndrome. The first patient can get like an ECG in the hospital by coincidence for another reason, and they find a Brugada pattern on the ECG. Then we have patients who have a family with a mutation in their family, or sudden cardiac death in their family. And then there's a third kind of patients who have symptoms, and then with the diagnostic they find out there's Brugada syndrome. There are three kinds of types of Brugada patterns. You can see in the right upper area. You have type 1, 2, and 3. Type 1 is the diagnostic type and is defined as a coved ST elevation of more than 2 millimeters in V1 or V2. And then there's type 2 and 3, which are not diagnostic for Brugada. Type 1 can be spontaneous, so that you see it right away on the ECG, or it can be induced after a sodium channel blocker, for example, an Ashmeline test. So patients can also have like a normal ECG, or have a type 2 or 3 on the ECG, and can form a type 1 after induction with a sodium channel blocker. There's an association with fever, because the channels seem to be susceptible for temperature. So patients with Brugada syndrome are advised to always, with a fever, very aggressively treat themselves with paracetamol to reduce their temperature. So as I said already, there's a connection with sudden cardiac death. Brugada syndrome is accountable for 12% of all the sudden cardiac deaths, and of 20% of all the sudden cardiac deaths with patients with structurally normal hearts, which is the previous definition of Brugada syndrome. And the reason people have sudden cardiac death is because there is a higher prevalence of ventricular arrhythmias in these patients. Previous research shows that sudden cardiac death survivors with Brugada syndrome show abnormalities in electrical conduction. And the past couple of years, they saw in research that the ventricular arrhythmias seem to be becoming out of the right ventricle, and especially the RVOT seem to be prone for ventricular arrhythmias. It's a genetic disease, and the gene that's been linked to this disease is the SCN5A mutation. And this is a gene that's accountable for the alpha subunit of the cardiac sodium channel NaV1.5, which is accountable for the rapid obstruct of the action potential, also the phase 0 of the action potential. So that is a quick introduction into Brugada syndrome, more of the clinically wise. Now we'll go a little bit into previous research that has been done, especially on the RV and right ventricle involvement and the combination with the gene mutation. In 2011, Matthews et al. Did an experimental research on a mouse model where they used wild-type mice and mutated mice with the SCN5H mutation. And they gave these mice flecainide, which is also a sodium channel blocker. And what they saw is that wild-type mice had no significant heterogeneities in the action potential, but mice who had the mutation and got flecainide shows increased refractory periods and increase in action potential alternance, and especially in the right ventricle epicardium, which you can see on the right side of the picture. So on the left side, I made a flow chart to put this a little bit into place, because Matthews et al. Really looked at cellular level with differences between the endo and epicardial cells. And they saw that there was more action potential duration heterogeneity, which they conclude that can cause transmural gradients of repolarization. And therefore, the RV seems to be prone for ventricular arrhythmias in mutated mice. But they looked only on cellular level, so they really took these cells apart. And what is not prescribed is that on tissue level, it may function differently because myocytes are really well coupled and there's an electrolytic interaction between myocytes. So what we see on cellular level, if we take the cell parts, might not count for tissue level. And there might be a reduction of action potential dispersion, which alters this kind of this pathophysiology a little bit, because it doesn't really have to, there don't have to be ventricular arrhythmias necessarily if it on tissue level it's reduced. So basically in previous research, there are two kind of streams of hypotheses in the pathophysiology of Brugada syndrome. And one at A is the repolarization hypothesis, which basically shows that there is action potential heterogeneity between endo and epicardial, the epicardial layer, which can cause arrhythmias. And then there's another stream of hypothesis, which this article is telling more about into deepness, is the conduction hypothesis. And they try to explain the pathophysiology more on a tissue level. And they say that structural discontinuities in tissue are the cause of ventricular arrhythmias by that these structural continuities form a conduction block and therefore cause re-entry and therefore cause a VT. So what was the aim of this study? The aim of this study is that they wanted to find out what creates the increased arrhythmogenesis in the RV of mutated mice hearts. And they did that by trying to identify the interventricular differences in mice hearts. And they looked at two different factors. They looked at the transmural electrophysiology by action potential duration, conduction velocity, and activation time variability. And they also looked at the structural differences between left and right ventricle in wild-type mice and in mutated mice. And they tried to see how much non-vascular clefts there were, how much fibrosis there were, and the role of these non-conducting clefts on the arrhythmias. Then the methods, they used isolated hearts, 11 mutated hearts and 10 wild-type hearts. And they paced from the apex with a baseline frequency of 7 Hertz. For imaging, they used Weld-field and 2-photon microscope optical mapping for the electrophysiological data. And for the fibrosis, they used histological staining by Mason's trichome staining. Later on in the article, I will talk about that later in the results. They try to mimic the SCN5H mutation by reducing the sodium channel function, and they do that with the pharmacological drug tetrodotoxin. And for the function of the cleft size, they use computer modeling with a 2D model of a mesh with clefts and the Baudorento mouse achonic model. So then in the results of the article, they showed quite a lot of results, so I tried to get you through it. First, they looked at the action potential and the action potential duration rise time. And what they saw in the upper right picture is here you see the right ventricle, and they saw in red is the mutated mice that they had a longer action potential duration rise time in the right ventricle compared to mice who didn't have the mutation. On the lower picture, you see that the rise time is also, the action potential rise time is also longer in mutated mice compared to the wild-type mice that has been visualized in black. Then the transmural differences, they looked at the conduction velocity in wild-type versus mutated mice. And what you here can see is the upper one in black is the wild-type mice, that it has a higher conduction velocity compared to mutated mice. But what you also can see is the closed dot is the right ventricle and the open dot is the left ventricle. And what they did is they hired up the frequency of the stimulus, so from 7 until 9 Hertz. And what they see is that not only the conduction velocity is lower in mutated mice, but especially it reduces in mutated mice when the frequency goes up in the right ventricle and less in the left ventricle. So the right ventricle seems to be more susceptible in mutated mice for the conduction velocity.
Can I ask a question?
Yeah, of course.
Conduction velocity measurement is very difficult. So the question is, how did they do it? I mean, they use transmural measurements apparently, but if you don't know the path along which the activation takes place, it's very difficult to come to a conduction velocity.
Yeah.
I always say that you better, in that case, report activation time differences rather than conduction velocity.
Yeah.
So how did they do it? I mean, 10 centimeters per second is very low. You only find that when the calcium current is only active. So I would almost call this block, for instance. So the question is, how did they measure it?
So they used 2-photon microscopy to visualize it. And what they described in the methods was that they measured the delay in activation.
Yeah.
So the difference between activation times. So I suppose that what they meant is the delay between endo and epicardio.
Yeah.
If I had it right. But more into details, they didn't went in the methods.
So essentially, you can't exclude that the path of activation is longer in the mutant mice than in the.
Yeah, no, you mean by like a conduction block or.
Yeah, if they or when it takes a zigzag route, for instance.
Yeah, no, they didn't describe that at least. So.
Okay.
No.
Thanks.
Here they visualized epicardial activation maps of the right ventricle of wild type, that's the upper one, and mutated mice. And what you see, there's a significant slowing and dispersion of activation in the right ventricle of the mutated hearts, what you see less type hearts. So here also it's that the right ventricle seems to be more susceptible. Then they looked at action potential activation variability, also between wild type, mutated, and between right ventricle and left ventricle. And what they see that the mean activation, action potential activation variability is higher in the RV of mutated mice. And this difference you don't see in the left ventricle between mutated mice and the wild type mice. Yeah, here they visualized the activation delay in the right ventricle. And what you can see is that when they higher up the frequency from 7 Hertz to 10 Hertz, is that in both wild type as well as in the mutated mice, there is an activation delay, but this delay was higher in the mutated mice compared to the wild type. And this is not seen in the left ventricle. So why is the RV more susceptible for these electrophysiological changes? They try to quantify the non-vascular clefts. So the thought was there should be some clefts that can cause, for example, conduction blocks. And what they saw is that in the right ventricle, there's a higher percentage of area of clefts, but not only in mutated mice, but also in the wild type mice. So it seems to be that also healthy hearts of mice, at least, have a higher percentage of area of clefts in the right ventricle compared to the left ventricle. And this could not be explained by the percentage of fibrosis, because you see that the area of fibrosis in the right ventricle doesn't correlate with the area of clefts that is seen on the left side of the picture. Then they looked at the cleft size, so how big the clefts exactly were. And what they see is in the right ventricle, the cleft size also seems to be bigger. And they see this both in wild type as well as in the mutated mice. So also in healthy hearts, it seems the cleft size seems to be higher in the right ventricle. So the conclusion they made out of this is that like the mutation, the SCN5H mutation, does not influence the cleft size of the RV, since it's also present in wild type mice. So the question arises then, is the presence of this high cleft size in the right ventricle in combination with the sodium channel dysfunction that comes along with the mutation, is the combination of that arrhythmogenic? So how did they do this? They took wild type young mice hearts, so healthy hearts, not mutated, and they took young hearts to prevent fibrosis that you can have in old hearts. And they were mimicking the mutation by reducing the sodium channel function by tetrodotoxin. And they try to see, like, are there differences in the right ventricle conduction after reducing the function of these sodium channels in healthy hearts, basically. And what they saw in the upper right picture is that the APD in the right ventricle after reducing the function of sodium channels is prolonged. So there seems to be an effect in the RV. And this is not very much seen in the left ventricle. Also, the APD rise seems to be higher in the right ventricle after giving the pharmacological agents. And the variability in activation time is also much higher in the right ventricle after reducing the function of sodium channels in the right ventricle, and which is something you don't see in the left ventricle. And these outcomes, they seem to be higher if there's presence of lung cleft. So they basically looked at the epicardial activation time, and they compared between short clefts and long clefts, because they know in the right ventricle there are more bigger clefts present than shorter ones. And they saw that the longer the clefts, the more long clefts there are, the higher effects there is on reduction of the sodium channel. So there's a higher action potential duration. In the end, they made a color map activation of the activation time. And on the left, you see a normal function of the sodium channel. And on the right, they mimicked the reduction of the sodium channel. So the sodium channel doesn't work properly. And you see that already without any clefts, that there's an activation delay when there's a low function of the sodium channels. When they add clefts, you see that the conduction delay is even bigger. And when they introduce lung clefts in combination with the low function of the sodium channel, you see that there's an activation delay. In the red arrows, there's a conduction slowing, and the black arrows mimic the conduction blocks that exist. They also made
this is a computer simulation, right?
Yeah, it's a computer modeling. Sorry, yeah. They did this with a computer modeling of based on a mouse model.
Yeah.
Yeah. And they had a nice clip, so I want to show you. The bottom one is the one with the reduced sodium channel and the big clefts, and you can see how the propagation goes. So it's a lot more slower than the upper one, and these conduction blocks are potentially can form re-entry and can cause arrhythmia. So I summarized what they did a bit in this flow chart or the scheme. So on sodium channel function loss causes activation heterogeneity and transmural dispersion of the action potential. But in combination with the structural discontinuities of the right ventricle, so these clefts, they can cause conduction slowing and conduction block. And this effect is higher when the cleft size increases. This conduction slow and the conduction block can cause re-entry and therefore can be like in the pathophysiology of causing ventricular arrhythmias in Brugada syndrome. Some limitations of this this article. It was not possible to image the two photon layers simultaneously during the frequency, during the simulation. So they used the steady state behavior to image the synchronized, they synchronized it to the stimulus, sorry, to make images, which is not ideal, but it was the best they could do. Yeah, this is done experimental in mice hearts, which is not totally comparable to a human heart. What they did in the computer modeling is that they used first the mice heart, but they also used a guinea pig computer model, which is more likable to the human heart. And that was not different from the mice model. So therefore they say the mice model is quite all right in this article. They use short axis images, so there's no fiber orientation that they took into account in this. They computer modeled the clefts, and therefore the non-conducting clefts are like empty spaces, but in real tissue there's of course some extracellular fluid. It's all a bit different than a computer model, and they use 2D computer modeling, which does not take in account the coupling and electrostatic load of the tissue. So the conclusion of this article is the physiological structure differences of the ventricles in combination with loss of function of sodium makes the right ventricle more prone for arrhythmia. That was my presentation.
Very well done. So, Rick, are you there? I was wondering whether you have seen some of these left-right differences in tissue discontinuities in human hearts. Rick, there. Oh, he doesn't have a microphone, he says. Okay. He will try to type his answer, so you can follow it in the chat. So in the meantime,
yeah, I mean, I have a number of questions, but first I'm glad to see you did something with computer modeling. I remember teaching a course to you guys about modeling, and I'm glad you chose a paper that had a little piece, and I hope that you could understand it, which it sounded like you did. You understood its strengths and its limitations. So that's just a comment. But a question I have is kind of for everybody, is the role of Purkinje network if you're looking at endoepicardial propagation and vice versa. I know in different species, you have different faster conducting pathways, and electrical waves can go in and out of the Purkinje network, which will change the activation delays essentially. And I would imagine with a faulty sodium channel current, you may not be able to go in or out of the Purkinje network, the same way that you would within a healthy tissue. And it may be species dependent. So for me, what I find interesting is whether you paste the endo or the epi, do you think you have the same results for what you're finding in this kind of case? Because you mentioned fiber orientation, you mentioned, looking at just clefts, it seems, okay, yes, maybe if you paste endo and epi within the computer model, but I'm not sure if you ran across any other studies which look at more so like PBC differences between endo and epi in Brugada syndrome. But do you think the results would be the same if you paste the endo versus epi?
I think I did not look up into that specific area for other articles, so I don't have a clear answer on that. But I can imagine that like mice hearts, the Purkinje fibers are way different because they have such a fast heart rate compared to human hearts also. So I think there would be differences, but what these differences are, I'm not there to tell you.
Yeah.
Maybe other people know something about
Yeah,
this.
it's a very complicated question, so I don't expect you to have the answer to that. It's more of a to the entire group, because I myself, when I go to mouse models, for example, the first thing I always ask myself is how the structure and the electrophysiology are different than a human. So I always keep that in my mind when I'm doing these studies. And one of the things is I don't know fiber orientation in the RV of a mouse. What is the Purkinje network setup? So I think it would be something to look into as a further kind of interesting.
I think the Purkinje system does not extend that high into the right ventricle. And the right ventricle is, the RVOT is relatively devoid of Purkinje cells. So you're at the end of the activation pathway, which explains more or less why these conduction delays lead to conduction block, because there's no alternative pathway by which the activation wave can reach the RVOT if you have block. So I think the influence of the Purkinje is relatively small in the RVOT, although the whole activation pattern before that, of course, is severely influenced by it. Yeah, I was wondering, Jason, Talita mentioned the difference between human and guinea pig and mouse models. This relates more to the repolarization pattern, of course, but how do you feel about the conclusions in relation to these differences in model?
In the ionic model choices, well, I mean, if you're looking at activation overall at a cycle length that isn't rapid, it doesn't mean a whole lot to me. I mean, it's no matter whether you use any ionic model, most of them stem from the original kind of guinea pig design, right?
Yeah.
And so, whether you change the upstroke velocity of an ionic model, it doesn't really depend on the species too much than the actual quantity that you're changing.
Yeah.
However, if you look at repolarization and you're starting to pace a little more rapidly, then you start to engage the restitution curves, and then it becomes important. Very important, because then everything starts to feed back. So if you're just looking at activation, in this case, simple propagating waves, then I'm not it isn't a big issue.
For the depolarization, it's not very different compared to human hearts.
No, exactly. But there have been reports that the transient outward current and the calcium current contribute to conduction velocity by increasing the transmembrane differences. So if you have a lot of ITO, then if you have a little bit of delay, then there is less potential difference left. So it does influence conduction then in that case. I think Mark Potts has shown that in the model of Brugada syndrome. And the same goes for calcium current. If there's a lot of calcium current, you maintain conduction over longer delays. So Rick has answered in the chat. I'm not sure whether you can see it, but there was a question. I asked him the question whether there are left-right differences in human hearts as well, as we've seen. And he I'll try to read it. The left-right differences were interesting. Does this suggest an intrinsic baseline difference of SCN5A between left and right? He means, I think. That's a good suggestion. So what do you think about it, Talita? Are there baseline left-right differences in SCN5A?
I do not think so. Not per se, not that I know of yet, because I think there are left-right differences in every human, and like in combination with the mutation, they might get their phenotype. You know what I mean? I think.
No.
No. Okay.
Well, yeah, well, I think if you read Bowkens, one of the references there, he has shown that there is a left-right difference, but there's a difference between the RVOT and the rest of the heart in SCN5A. So there's less sodium channels in the RVOT as compared to the RV and the LV. And that relates to a developmental difference in the RVOT myocardium.
Oh, from like embryology onward.
Yes.
Yeah. I like that. Yeah.
And the same goes for some gap junctional differences that are different that are less in the RVOT. And then let me read another comment of Rick. Following on from the simulation comment from Jason, given that clefts were measured from tissue, could a more realistic model of clefts be formed? Clefts would primarily be subendocardial, I guess. I'm not sure about that, to be honest, but how does transmurality of clefts play a role? Jason, I think that's one for you.
I mean, from a modeling standpoint, you can always add a gradient of cleft size or whatever you want. That's a question that only the computers could answer, but yes, you could totally do that. But regarding cleft size, we always kind of, in computer models, don't model the structure as a kind of discrete structure. It's usually continuous, right? So you change the velocities in your model based on hypotheses, whether it's connexin changes transmurally, or whether it's changes in cleft size or something like this, where we would have to do a more discrete model. And if you had some imaging data, per se, from maybe where your question with Rick was going, if he's got some good micro CT data, yeah, you can adjust the model, and there's other modeling techniques to use that are very, fine scale, which you would need. And it's always possible. It just depends on what you're trying to show. But what's interesting to me is the RV is so thin. How much do you have of endocardial structures playing a role in all this overall CV as well in the endocardial area versus an LV is much thicker, right? So, if you're looking at delays endoepi and you don't have a model that includes an endocardial structures and you shrink it to a smaller size, this is another point where you can always keep going on and on and on. So the power of this modeling study here was it was simple. They kept it simple as possible to make a point, but then if you really want to get down to what the mechanism is, I think you have to go way more complex. And particularly in the RVOT, where there are no Purkinje fibers, which is all of these things, so it's pretty much structural, so you got to have really good imaging.
I agree.
What would you if you were in this study, what kind of computer model would you use?
Well, I know Martin Bishop, so I would say the same. I think the point they were making is, the computer modeling again in this study shouldn't trump the experimental side, which I think is really the important part. They're trying to explain, I think, one case where you can have conduction slowing with something that naturally occurs. Because you said in the control and the wild type, the cleft size really didn't modify, but however you modify the sodium channel under that circumstance, then all of a sudden you have something you may not have expected. So they're just highlighting one possible case of doing that. And the way they did it is fine. That's an acceptable approach. And the fact that it's in a mouse heart in general, I would keep the modeling study simple. Now, if this was human and you had to directly link it to some clinical signals, then your model has to include a lot more complicated things. And you know, that's my opinion. If I was a reviewer on this, I would have kept their model simple. Yeah.
Yeah, I like simple models. That's how it should be. Rick suggests that the cleft should be subendocardial primarily, but I think Brugada syndrome is particularly, well, the changes that occur are particularly in the subepicardial area of the RVOT. At least that's the traditional way of looking at it. And a recent paper by Elijah Beer has shown that there is not only subepicardial changes in Brugada syndrome, but also in early repolarization syndrome, and not only in the right ventricle, but also in the left ventricle. So Brugada syndrome seems to be a subset of a subepicardial cardiomyopathy, is how we call it. There's some more from Rick. Human left-right difference is probably a good question for David. Yes, but he isn't there, so. But in relation to complex microstructure, obviously a major role for the RVOT is important. I think the microstructurally complex hotspots of the left ventricle are simply different, but the insertion of papillary muscles is important. Yeah, that's a very interesting suggestion. Increased cell orientation variability and cleft density likely presents a good marker for arrhythmia anchoring sites. Yes, those are very valid points, I think. Thank you, Rick. Next time, get a microphone.
Can I ask something really quick, maybe for you, Ruben? Because I like they didn't see any differences in these clefts necessarily between the healthy hearts and the non-healthy hearts, right? And I wonder if there is a physiological reason why you would have more of the clefts in the right ventricle,
yes,
compared to the left. Because like many things in biology are reason-driven, right? Like
yes. Well, I don't have an explanation, but one potential explanation is that the wall stress is determined by the wall thickness as well as the diameter of the ventricle. And maybe there's more wall stress despite the lower pressure. I'm not sure, but that could generate secondary differences in fibrosis maybe. But I'm speculating.
okay, thank you.
Anyone else who can find a physiological meaning for these right-left differences? Why would they be there? Well, silence is also an answer, I suppose. Okay, Rick says, apologizes because his laptop is broken. Yeah. Okay, anything else? I'm slightly disappointed by the fact that they haven't mentioned Hogendijk at all. It's one of my own publications. Not because I want myself cited, but Mark Hogendijk essentially demonstrated this mechanism before, also experimentally by looking at tissue sections in which he made a barrier and then applying a sodium channel blocker. And then he exactly showed the same phenomenon, that you have conduction block only when you have the structural abnormalities in addition to a sodium channel blocker. So that led us to conclude that the sodium channel blocker is a modulating factor of Brugada syndrome, and that you need these structural abnormalities to start with. This is exactly what this group is showing, I think.
Yeah.
So with fibrosis, I know that Brugada syndrome happens at many different ages, right? You can have the
Yeah.
sudden cardiac death.
Yeah.
But is it more frequent in older? I mean, given the level of fibrosis, I don't know much about it in the RVOT versus the RV.
Yes.
I don't know a lot about that. Has there been studies that look at the distribution of fibrosis and the quantity based on age or hormones or sex or anything? No.
Yeah, well, that's a good remark, because Brugada syndrome is described in the younger population, but not in children. Well, there are some cases in children, but then they have a lot of structural abnormalities there. So maybe we are looking at aging that causes Brugada syndrome to occur in a relatively young age, but not necessarily at a young age. So typically it's 30 to 40 years old male that have it. And in Asian countries more than in Western countries. So I don't know.
I was wondering this too while reading this article, because they basically say like a reduction of sodium channel in combination with these clefts makes it happen that the RV is more prone for arrhythmias, so that arrhythmias can happen.
Yeah.
And it was not due to fibrosis, but I was wondering, like if people with Brugada grow older and they didn't have arrhythmias, if they are more prone to get arrhythmias because they have a combination of these clefts,
Exactly.
plus like getting fibrosis because of an older age.
Exactly. Yeah.
But yeah, you see some patients who have Brugada their whole life and then suddenly get arrhythmias during an old age. So I don't know if that's related, but
Yeah. No, it's the same way I think about it, that the fibrosis potentially is a progressive phenomenon with age, and that at a certain moment you reach a stage that there's just enough fibrosis with an addition of a sodium channel blocking drug or mutation or diet. I mean, I've studied sodium function in animals that were fed a high diet with fish oil, and and fish oil acts as a sodium channel blocker. So if you have a large meal of fish, for instance, fatty fish, then you may just have the exact required degree of sodium channel blockade that blocks you. Well, I'm just suggesting, but there are many more sodium channel blockers, for instance, and even a high frequency causes a reduction of sodium channel function, sodium current. Here we get philosophy from Rick. I'll read it again, Rick. Slightly more philosophical point. But the fact that the RV endocardium is continuously bathed in deoxygenated blood, yeah, that's a good point. Compared to the oxygenated left ventricle, there must be adaptive differences to metabolism, Guido, that's for you, and downstream electromechanical function between the two ventricles as a result of this. That's an interesting suggestion. I've tried to dig out some literature on this rather unsuccessfully, so it seems to be overlooked completely. It's a nice idea, Rick.
Interesting.
It would affect the subendocardium primarily, I would say, rather than the subepicardium. We've looked at the influence of the oxygen gradient in right ventricle, and it reaches about 400 microns from the subendocardium. So I'm not sure whether this will have a full effect on the myocardium. Guido, do you have anything to add about the oxygen?
No, I'm sorry. I was discussing a problem with an instrument just right now. So I actually missed this last philosophical point.
Okay, maybe
Sorry.
later. Talk about it with Rick.
Sorry, could you repeat that? I would like to answer if I can.
Rick suggests that the subendocardia of the right ventricle is subject
Right.
to desoxygenated blood, and
Right.
for the left ventricle, it's fully oxygenated.
Okay.
So there must be some adaptive metabolic adaptation.
It's not.
in the right.
It's not unlikely, for
No.
sure. I mean, there is a difference in oxidative stress between left and right atrium. So
Yeah.
for sure, this is due to some kind of different oxygen tension, or it might be even the sensitivity to different
Yes.
level of hypoxia might be including adaptive mechanisms. So why not? It's,
No.
from the philosophical point of view, it's definitely possible.
Yeah, maybe we can test it. It's a nice idea.
Yeah.
Could also be a reasoning why there are possibly more clefts
Clefts, yeah,
on the endocardium.
yeah.
Possibly.
Okay. Let's see what the time is. Yeah, we have 5 minutes to go, but we can stop early if there are no more questions, of course. Any more comments? Talita, what do you think of the paper? If you grade it from 0 to 10?
No, I think it was a really good paper. They really did a lot of experiments, and what I really liked about this paper, there was a storyline in it. So they really explained why they did it, from which point of view, and in steps. And of course, there are some things about this article that, are really not the ideal situation, but I think they made like a very nice conclusion for something that's possibly very interesting in the pathophysiology.
Yeah. So,
And if you would rate it in terms of reproducibility, how much would you rate it? Like, would you be able to reproduce it on a scale of 1 to 10?
I find that's very hard because I don't have a lot of experience with like animal models and experiments. So I don't know.
It's just if the
6%.
method is clear.
Sorry?
It's just a measure whether the methods are clear or not to you.
Yeah.
Clear enough to reproduce.
Yeah.
Doesn't matter if it's what model they're using.
I think I would say 7.
Okay,
I think.
that's not that bad.
oh, that's very good.
Yeah,
Okay.
I don't know.
Thanks.
Yeah, I agree. It's an interesting paper, and the methods are well described. Yeah.
Yeah.
Good.
Okay.
Thanks again.
Okay, I think this concludes our journal club. Talita, would you mind staying behind? I want to ask
of
you
course.
something. Yeah.
Yeah.
And the others, well, see you next week, I hope, or next month, when we'll have a unknown paper.
Well, thank you very much. You did a great job.
Yeah.
Thank you.
Yeah, thank
Thank
you.
you.
Okay. Bye-bye.
Bye-bye.